All right, I've started the recording. Let me show you a few. This is one that we don't see often, but you folks will recognize it. So let me show you the chest radiographs. Let me bring in a recent one. And the difference here in time is 2014 versus 2017. And one thing that you'll see that plays into this is the fact that currently the pulmonary arteries are enlarged, and he is known to have pulmonary hypertension that's new from before. And there's some history that I'm going to withhold for a moment that plays into that. But I did notice in medical records recently that while he was known to have pulmonary hypertension, they weren't entirely sure of the etiology of it. So let me show you two images, one from December and another one from, sorry, let me get this one. I thought I had another one. I do. So these two exams are, and I thought I had an old one, sorry, here we go. I'm messing up here, sorry. I thought I had a previous CT. Oh, I do. Sorry. So this is December 21, and it's very abnormal. So let me just scroll through this one first. So there is a little interstitial edema in the left upper lobe, and actually I'm not entirely sure why that is the case. But if you look in the background, you can see a pattern of centrilobular opacities. And if I scroll through it, you'll recognize that these are nodular but branching opacities. So let me show you a more recent one, which is this one. And you'll see that these nodules, or these opacities, appear larger. And now let me show you the MIPS, which really brings these out. So I'll bring these up. And now it's very apparent that these are centrilobular, but they are related to pulmonary arteries in the pulmonary lobules and not pulmonary veins. So let me just mag this one up and find a place where I can see, for example, here, that the pulmonary veins, septal structures, are okay. Here's a nice example where the pulmonary veins are okay, but between the pulmonary veins in the center of the pulmonary lobules are all these branching opacities. So this is very typical of excipient lung and definitely a very good cause for pulmonary hypertension. So he does have a history of drug abuse, and I think making this observation about what these vessels are, it's really a slam dunk. There's no differential diagnosis for this. So we've shown this one before, but this is a really nice example of it. David, I think you've seen that one.
Yeah, I love it.
Yeah,
it's beauteous. What's the interval between the two CT scans now? Just a few days,
very
right? A week?
Yeah, this one, previous one was 12/21. Sorry, I got these mixed up. But I don't know if he injected more between the two, or whether that's the granulomatous response to the presence of the material. But it seems
he probably re-injected.
Pardon?
He probably re-injected. He probably injected again.
One would think, isn't it?
That's a dramatic worsening.
Yeah. So I let them know that we definitely know what the cause of the pulmonary hypertension is. There was a mention previously of intravenous talcosis, but for some reason there was miscommunication because they thought we were perhaps referring to inhaled form of talcosis, and we were not.
Right.
So it's important to use the right words. I don't know why he has lymph node enlargement. There may be a different and another reason for it. I don't know what that is about. And he's had some lymph node enlargement before as well, but I don't know what that's due to.
Howard, did the pulmonary artery dilate between these two scans? Is it even more dilated? No, it's about the same.
Yeah, it's about the same. Let me see if I've actually got the dates correct. Yeah. Oh, yeah, let's go look at the right heart, and you'll see how big these chambers are. So the right ventricle and the right atrium are dilated. It's known to have pulmonary hypertension. The other thing that I was speculating about is whether in the past he had actual pulmonary infarcts, perhaps for another reason. But these are unchanged, but these are relatively large opacities, so I don't know what to make of these down here. But the other findings are pretty dramatic.
No, he didn't have an intravenous catheter in place, or does he? He's got a bunch of tubing in front of his there.
Yeah, I don't.
Because the availability is a big component in this. They have a catheter.
Yeah, that's the one thing that would really make it a slam dunk. I mean, not that it already isn't one. Did he have a left upper extremity pick on that radiograph you just showed?
Yeah,
he does.
Now.
Yeah, he does right there. Yeah.
Yeah, this is the one on the 30th, which he didn't have before. So one wonders, well, actually, I'll take that back. He did have it before too. So he does have a pick in, sorry. Yeah.
David,
cool.
David, was it your article that coined the term excipient lung, the one in AJR?
Right, Sudhakar came to that. Yeah, it's Sudhakar Pipavat's nomenclature, which I think is very helpful.
I agree, because like Howard just referenced, that people confuse it with inhalation talcosis.
Right.
Right. So that was the dramatic case of the week. This one is more mundane, but I've not seen this before, but I'll show it to you in case you haven't. So just by pure chance, I saw one of these, and then I told Leif about it, and he said, oh, I've seen that, and he showed me the other one. So for this patient, let me get to the right spot, make sure I get the right area. Okay, so this is the one here. So this patient has nodules, and one of these was biopsied. What I saw that drew my attention the other day was this right here. So this is obviously a nodular lesion, and I saw this little worm-like opacity right there, which is new from August 16. So that's a new finding right there. So keep that in mind for a second. Then let me show you the second case that Leif told me about that shows a similar kind of finding. So let me bring this one up. This too is in the context of a nodule that was biopsied. And for this particular patient, what is new is this right here. So here is, in this case, another little worm, except this worm is a little bit straighter. So let me show you that he had a biopsy procedure in August. Sorry for making these jump around. I don't know why my Sarix does that. Sorry. But here you can see they did a biopsy of a nodule up in the apical portion of the lung previously. And going towards it is that thing right there. So let me go back to the previous one just to show you what this is. And let's see if I actually have it there. I think I do have a picture of it here, I think. Or maybe I don't on this one, sorry. Because this is BioSentry gel. So let me go to show you this. Oh, here we go. So this is what these guys do now. I don't know how long they've been doing this, but they have been using this thing called a hydrogel plug to try and diminish the incidence of pneumothorax. So after they do the procedure, this little plug called hydrogel, I don't know exactly what hydrogel is or what makes it up, but that's basically injected in the tract. And I guess they basically injected at the level of the biopsy, and as they withdraw the needle to the pleural surface and beyond, they inject that. Travis, do you guys use anything like this?
No, we don't use that. And I was also going to comment, we don't do CT fluoro anymore. I saw that was a nice series of images of the fluoroscopic biopsy.
Yeah. So
CT fluoro is awesome. Why don't you use it anymore?
I don't know. It seems,
do you even do biopsies anymore?
yeah.
Or you do?
We do them all we just do CT, reposition, image again, reposition.
Oh, it's so painful.
Yeah.
Okay.
He still has fingers.
Pardon? So that's what that stuff. It's the.
That material is really cool. I haven't seen that before.
Yeah. I don't know why it's so opaque. I guess it just absorbs water, and I think eventually it kind of dissolves, apparently. I think. I'm not entirely sure about the fate of it. All right, let me show you this one. This is actually a bone case, but let me bring these two up. Saw it today, so I'll give you a moment to look at these two next to each other and look for bone findings. Yes, between the two, the size of the cardiac chambers is increased. The vessels are more distended, but let me just bring this one up and show you the clavicles.
Oh, lovely.
And I think David will like this one. You know, this one attracted my attention because I don't think I've seen subperiosteal bone resorption here, but this degree involving the entire outer portion of the clavicle where it really sort of disappears is quite impressive. And renal osteodystrophy, of course. And the spine also goes sclerosis.
Is that pleural fluid that's more inferiorly on the left? Or what's that kind of vague ovoid opacity peripherally over the heart?
Let me see if I can tell whether it is something extreme.
Or is it a big brown tumor or something?
Going in that direction. I can't tell what that is, if it's anything. Maybe it's just some atelectasis, I think.
It looks as if there's an expanded, though, lytic lesion in the rib, the posterior rib.
I'm not sure yet.
Yeah, I thought you were going with brown tumor.
Oh, I don't really know. I'll have to look some more to see if I can tell, but that's a good thought. And I should try and look at the rib to see if there is a brown tumor of rib involving the anterior or posterior. That's a good thought. I wonder if
that one posterolateral rib is no longer visible, whatever that is, 3, 4, looks like 8.
Yeah, it looks as if it's been destroyed, blown out.
in here, maybe from
right.
Here. And this could be an extrapleural sign of a rib. That's a good thought. I want to see. I don't think I have CTs to confirm that, but that's a good thought. This person does have end-stage renal disease and has it for many years. He's hemodialysis, so there's no reason why this person can't get osteoblastoma or brown tumor.
There's another clavicle finding that's interesting. If you could scroll back to the clavicles and mag it up, and that is you lose the corticomedullary border here. It is sort of merged so that you've got these thickened trabeculae that smudge the endosteal surface of the cortex, and so it becomes hard to distinguish cortex from medulla in the bone, and that
right here.
That's sort of sclerotic. Yeah, and the top surface of the cortex too is ill-defined.
Right there, maybe.
Right, because of the thickening of the trabeculae, you lose your sharp definition. And then this fuzzing out of the distal clavicle is classic. I learned that at UCSF when they were doing a lot of renal transplants when I was there, and they had a lot of people with chronic renal failure, and they said, look at the distal clavicles all the time. And this indistinctness, normally there's a nice sharp cortical envelope around the distal end of the clavicle. In this case, it's fuzzed. Sometimes it actually gets striated. It looks like a paintbrush.
Okay.
But I think Howard, there's also on the other side, there's also erosion of the inferior surface of the clavicle out there from the corticoclavicular ligament. And a lot of these findings in secondary hyperparathyroidism resemble rheumatoid arthritis because they're both sort of synovitis sorts of things. But the cortex along the undersurface of the clavicle there is ill-defined and kind of ratted up. So, yeah, right through there. So I think that's part of the involvement of this bone.
Yeah. exactly. Good. Yeah, I'm not sure I picked that up or I went right by that, so I'm going to look some more and see if I can figure that out and look at the lateral more carefully to see whether we can identify potential brown tumor of rib. Great. Yep.
Yeah, that'd be great.
Okay, let's see if I have another one that's particularly interesting. Well, let me stop there. The other one I have is not that interesting. Okay, I think I have control here. I think I do. Travis, hold on a second. Let me just bring this up. Who wants to go next?
I
got some cases. Oh, sorry, Dave. You go ahead.
Mine will be quick. I might have to leave a little early today, so
yeah, please go.
Okay, David. Here we go.
okay. Should be showing a CT scan.
Yep.
This is from 2010, and keep an eye on the anterior mediastinum because it looks pretty normal here. We have some fat in the anterior junction line there, looking pretty good. We do have some pleural abnormality here in the right hemithorax, and we have some adjacent atelectasis in the lung here, some round atelectasis and some radial bands and things like that. So we have a pleural process at this point. And then fast forward 7 years to 2017, and we still have a pleural process here on the right, a little bit more pleural thickening posteriorly than before. Now we have this anterior mediastinal process here with this big band of tissue that shouldn't be there. Plus we have left pleural process here with some loculated sort of trapped effusion there, some pleural thickening, visceral and parietal. And this person had a biopsy. Our considerations when we see something in mediastinal fat and we see something in the pleura, we start to think about infiltrating disease like Erdheim-Chester, because we've seen this distribution of infiltration before with that. This is a chronic smoldering process. So the person had a biopsy of this anterior mediastinal fibrous tissue, and they got back fibrous tissue with a lot of plasma cells in it. Furthermore, they biopsied there was a lymph node biopsied at the same time, something like this perhaps, but maybe not that one specifically. And that also showed an infiltration with plasma cells. And on plasma cell staining, they got up to 20% IgG4 positive plasma cells on staining. And so at this point, this is presumed IgG4 disease. And in terms of the patient's symptoms, they seem to be confined to the thorax with some shortness of breath, because you could see there must be some restriction caused by these pleural processes on both sides. But there was no evidence of autoimmune pancreatitis or abdominal findings that would go along with this. It wasn't not retroperitoneal fibrosis. And here's a PET scan showing some moderate uptake in that anterior mediastinal fat. There was fibrous tissue and this plasmacytic infiltration. It was polyclonal, so it's not considered to be a plasma cell tumor. And you can see the pleural uptake, modest pleural uptake on both sides too. So at this point, this
what's
is
interesting about this, that's odd about this for just pleural disease. There seem to be nodules in the extrapleural fat that are even FDG avid in the posterior hemithoraces, like nodules of tissue in the extrapleural fat.
Correct. So there are some hot lymph nodes here, and there's some mediastinal lymph nodes that were hot too, and that's why the biopsy included a mediastinal lymph node, and that had the same plasmacytic infiltration in it. So I think the lymph nodes are involved. By the way, this was not lymphoma, because that's another consideration, of course, for a diffuse disease in tissue. So it was not lymphoma, it was not Erdheim-Chester, and it was 20% positive for IgG4 staining among the plasma cells. So polyclonal
what it's doing to the aorta. It's really, you know, you see this with this and other processes that really thicken, and if even farther down, if you go to that contrast enhanced, it basically takes the aorta and turns it into an ovoid structure, and the aorta is a pretty high pressure, strong structure. And if you go to back to that contrast enhanced, I mean, it basically makes it look like a squishing it like it's the SVC. And I've seen a lot of these, like Erdheim chest drive in this, do that to the aorta, which is quite uncommon.
That's impressive.
Yeah, it takes a lot. Yeah,
he's got restriction of his aorta, not just of his lungs. So that's a very good point. So that shows you the mechanical
effect. Yeah.
We don't catch the kidneys by chance, do we, to see if there's a lot of tumor in the kidneys?
We do on the PET, and they're doing okay.
Okay.
Wow.
So no liver disease, no pancreas disease, no renal disease, no Erdheim-Chester halos around kidneys or anything like that. No retroperitoneal fibrosis squeezing ureters and things like that. But this, the spectrum of IgG4 disease is still, in the process of being defined. So at this point, we're seeking some outside consultations, but IgG4 is the working diagnosis.
It's interesting.
Very interesting.
Quick question on nomenclature. You mentioned those little soft tissue nodules. They're extra pleural. I would call those intercostal lymph nodes. Is that a term that other people use?
I don't know.
I think.
Are they retrocurl? I mean, where were they on the axial?
Oh, no, some of them were like just along the ribs. They're even higher up though than just the retro. Like that retrocurl, I agree, but even higher up, you see some there along all the ribs, right in there.
Oh,
Yeah.
yeah. I call those personally, intercostal nodes. I don't know what.
Okay.
I don't know if that's correct or not.
I don't know either, but that's since Howard mentioned them, I just thought I'd throw that out there because that's what I usually call them.
Yeah. Can you go back to David?
Let's go. Yeah.
Because I think I've seen a case before where I just thought there was tissue in those locations, and maybe about halfway down the chest, the nodules about, where was it that I saw it? Right there. Look at all that tissue. Yeah, right there. And on the other side. That's impressive.
Yeah.
I wonder if
I think they're discrete enough that I think nodes is a good idea, though. Don't you guys think that they're shaped like nodes?
you have lymphoid tissue there? I mean, nodes there? Lymph nodes in that location?
Well, this is an inflammatory process. He's got weird lymph nodes.
You'll occasionally see them with empyemas and with cancer.
Right.
Yeah,
I've seen with pleural tumors, including meso.
Yeah, mesos love to do those, guys.
Okay.
Okay. So let me show you another case. I think you'll agree that this is abnormal. This person has this widespread pleural tumor with some nodules and some loculation of effusion associated with it, but it's circumferential. It's probably going into, or at least abutting, perhaps going into mediastinal fat anteriorly, which is, mesothelioma loves to go into this anterior mediastinal fat. So when I see that, I think, this is definitely mesothelioma consideration, strong mesothelioma. And this was a sarcomatoid tumor on biopsy, and was sent to us with a diagnosis of sarcomatoid mesothelioma. But our pathologist examined all the stains, the cytochemistry, and didn't find the usual mesothelioma markers, did find TTF1 positivity, and this case was also reviewed at the Mayo Clinic. Let me just read what the Mayo Clinic had to say about this case. So the immune stains show positive staining of tumor cells for pankeratin, CAM52, Vimentin, CD99, along with patchy strong staining of TTF1, which doesn't go with meso at all. Weak focal nonspecific staining for calretinin, but no staining for a bunch of others, including mesothelin and desmin, or CD30. This immune phenotype offers no support for mesothelial differentiation despite the diffuse growth pattern. Instead, the findings are in keeping with a sarcomatoid carcinoma from the lung that has invaded the pleuron. And this process is known as pseudo mesothelioma. It's a growth pattern that mimics mesothelioma. And the presumptive mechanism is that there's a very peripheral lung lesion that invades the pleura and basically grows in the pleura, but doesn't, the lung nodule just sort of empties into the pleura, and you don't appreciate the lung primary source of this. So it's not as if you have a big lung mass that eventually gets into the pleura. This probably starts out very near the pleura and then just sort of grows in the pleural space. And so this is really pseudo mesothelioma. And it's really a lung carcinosarcoma, probably. Sorry, a lung, what do they say it? A sarcomatoid carcinoma of the lung. So there are no specific CT findings that tell you a diffuse pleural tumor is mesothelioma. There's nothing that's specific for mesothelioma. You know, I like to think that the anterior mediastinal fat invasion is a good sign of mesothelioma, but this case I think has it, and yet this is not a mesothelioma. So that breaks down too. I think one thing that can help is the pattern of metastasis, because mesotheliomas rarely metastasize remotely. I mean, they can do it maybe 10% of the time. And one of the sites that they almost never go to is bone. So if you end up with bone lesions, it's probably, and there's any ambiguity about the histologic type of the tumor, I think that's an argument against its being mesothelioma, because when they rarely metastasize outside the chest, you know, it's even rarer for it to go to bone. The other place I've never seen it, I've never seen mesothelioma, is adrenal glands. So if lung cancer is on the differential diagnosis of your pleural tumor, I think an adrenal metastasis would point me more strongly than, again, toward a lung cancer rather than a mesothelioma. I have not seen a case of meso go to adrenals, but if anybody has one, please share it with me. I'd like to have that counterexample to my assertion here. This fellow did have a pleural plaque on biopsy, so he did have asbestos exposure, but he's got pseudo mesothelioma. So here's one of those little nodules that gets into mediastinal fat from the adjacent pleural tumor. Again, this is a really good pattern for meso, and we should scrutinize these intercostal nodes in this person to see if there's any evidence of that. In this case too, I didn't do that so far. Okay, so pseudo mesothelioma.
That's a really interesting case. One question, David. So I guess when I see mesothelioma metastasize, I usually see it in the contralateral lung. That would be my vote for the most common site. Do you guys agree or disagree with that statement?
Not sure.
I think that's a common site when it does go abroad. Okay, and of course it can go through the diaphragm, end up in the upper abdomen, get into liver that way, can get down to kidney. So, but that's direct spread. It goes
direct spread through the chest wall.
Right, and it can get in. It can get into the mediastinum. It can be away from. For instance, I've seen it go into these diaphragmatic nodes here that are somewhat away from the pleural surface. So I think once it gets into the mediastinal tissue, then it probably spreads up and down via lymphatics and can move around in the mediastinum. And it does sometimes end up in supraclavicular nodes, I read, but I've not seen an example of that myself. Okay, those are the two cases I wanted to show.
Thank you. All right, who would like to go next?
I can shoot through my cases real quick.
Okay, Seth, give me a second. Here you go. Should get the prompt.
Yeah. So this is a case of a young woman who presented to our emergency department. This is an older case, you can see from the date, but no significant history, student at UCSD, healthy patient, came in feeling cough, feeling ill, had a chest x-ray, which, you know, definitely not normal. There's bronchial thickening, she's hyperinflated. You know, she had a presumptive diagnosis of some form of viral illness. Stop, go back. Sorry. Then this is literally 16 hours later. She develops pronounced consolidation peripherally. She's intubated. You can see the date is actually, I think it was like 12 hours later, not looking very good. She continues to progress and get worse and worse. Here she is in kind of diffuse consolidation, and she has a diagnosis of they were giving her presumptive diagnosis some viral illness with development of ARDS. Can you guys still hear me? Am I still there?
Yeah, I can hear you.
Oh, that's weird because it says Seth K just left on the screen. Anyways, so the patient was kind of sitting there. Every test that they ran was negative. Everything was kind of normal. She had an elevated white blood count, and then eventually they bronched her again. Well, they never bronched her. They were just presumably a viral illness, and you can see on the bronch that she had 71% eosinophils. And interestingly, so we know that in acute eosinophilic pneumonia, that the eosinophil count usually starts off normal. So here she is from a day of admission, and it really took about 5 days before her eosinophils started to skyrocket. And you can see here that her eosinophils started to skyrocket. Here is the CT from the case, where we see what we would expect with acute eosinophilic pneumonia, which basically looks like a combination of just either fluid overload, often with a component of either fluid overload and or DAD or pulmonary hemorrhage. Pathologically, we know that in fact it does represent a combination of capillary leak and alveolar leak, and is basically ARDS/DAD with eosinophils. She is quite wet as well. And after they made the diagnosis of acute eosinophilic pneumonia, now most eosinophilic pneumonia cases I have this one I think has usually a little more peripheral consolidation anyways. Nonetheless, they treat her, and then literally within about 12 hours of treating her with steroids, this is what her chest x-ray looks like. So, this is a case of acute eosinophilic pneumonia, unknown cause. She didn't claim to have done anything, started smoking or anything like that, and a really rapid improvement, as we know that these are extraordinarily steroid responsive, but it's just not a diagnosis we think of, and really needs to be made by the clinician on bronch, and also the delay in peripheral eosinophilia.
Background of asthma by any chance?
I have to look at her history. I agree. Her initial chest x-ray does look like that. I mean, that's what, looking at it when I read it, I thought she was some background of asthma. But to tell you the truth, Dave, I know chronic eosinophilic pneumonia has the association with hyperimmune states. I'm not sure about the association of, you may know, and you may be, about hyperimmune states and acute eosinophilic pneumonia development. You would assume that there would be some association, but I don't know.
Good point. I don't know.
Yeah.
And she wasn't taking any medication. There used to be.
That's the thing. So no medication. She
no health food like tryptophan or.
Exactly. Who knows? I mean, she's a student at UCSD. Her parents were there taking care of her. She denied anything according to the notes. I was looking for something, drug use, other drugs she was taking, started smoking at a party she was at, who knows? But there was absolutely no history. According to her, she's, quiet student that does nothing except study and then just got sick.
Might have been acquired from books.
Yeah, exactly.
Right.
This is just a quick case because it's just impressive. Another older case of a patient with atherosclerotic disease related aneurysms, and also a very nasty looking saphenous bypass graft with this huge defect in the aorta, presumably at the aortotomy site, with this massive thrombosed, partially thrombosed saphenous vein graft. And it's here, I'm assuming part of this is a pseudoaneurysm. It's really hard to tell. It's just a complete, here's a kind of sagittal view where there's these two very large defects in the aorta, presumably at the aortotomy sites where they put these things in. And then the grafts themselves are just diffusely aneurysmal and thrombosed. And I wouldn't know whether to call these, they're aneurysmal, but whether there's a pseudoaneurysm component or not. But anyways, that's just a pretty impressive case. The third case is my favorite case. So these last two are from University of Maryland. And this is just an awesome case. So this patient came in, she has a history of a hysterectomy about 2 months prior, came in with shortness of breath, has this lesion in her right ventricle, which we can see. and then has these scattered, well-rounded pulmonary nodules. I can tell you that she had her hysterectomy for fibroids, and this is her path, which shows this is the right ventricular lesion, and these are leiomyomas. So all the stuff that was taken out of her heart and presumably in her lung as well are metastasizing leiomyomas. As we know, they're kind of embolic process where portions of the benign lesions embolize from surgery and implant. And I've seen them in the lungs before. I've just never seen one in the heart. And it had implanted in a papillary muscle and grew. So this is a case of benign metastasizing leiomyomas with an RV mass.
Great.
And then this is just an awesome case because I miss my congenital heart disease stuff. A beautiful study. I miss my Siemens force, but nonetheless, we can see that there is a large right heart, a small left ventricle. There is this ASD, but we can follow the pulmonary veins, and we can follow all the pulmonary veins down. They don't connect to the left atrium like they should. They kind of go inferiorly and then drain into the IVC, all of them. So this is here's just kind of a nice look at it. So this is I don't know if it's technically infracardiac TAPVR. Most of the infracardiac TAPVRs I've seen hook into the IVC closer below the diaphragm, closer to the junction with the hepatic veins. But nonetheless, a cool case of a newborn with a cardiac / infracardiac TAPVR. Yeah, so those are, in 8 minutes, those are my 4 cases. And I'll send along the path on those, the leiomyoma. And we have an MR too. Charlie just sent it to me. I've been begging him for it. He just sent it to me, and I'll send that along as well.
Cool.
But yeah, no, this congenital heart stuff, I love it. It's pretty neat stuff. Okay, those are my cases.
Thank you. Great. Travis, are you up?
David, are you staying around?
For a couple more minutes.
Okay, Howard, I'm ready. I will, I'm going to switch to a different case really quick, just because I pulled these up from last week after the case that David showed. And these are the 2 cases I made reference to. Just really quick, you see this large right paratracheal / right apical lesion, and it exhibits a cervicothoracic spine here. And this is one that looked purely cystic when I reviewed this at Tumor Board. This was an outside study. This was when I was at Emory. Maybe a little bit of a wall to it. And I thought this was right paratracheal and was going to be a bronchogenic cyst or some sort of foregut duplication cyst. And this turned out to be a schwannoma. So that's one that looked very similar to the one that David showed last week.
Yeah.
And then here's the other one that I saw not too long after that. And this was actually, this was a PET CT that was done for a breast cancer. And I'll just show you the PET really quick. There's the breast cancer. And there was this enormous hypermetabolic thing in the left lung. And she had not even had a radiograph, is my understanding at this point. Or maybe maybe they picked it up on a CT or radiograph, but then did the PET. And here's same thing on the other side. This one is much more heterogeneous and has soft tissue components, but still looks like it descends down from around the lung apex. And of course, they were worried about a metastasis, and I thought this was, a lot bigger and looked like it could be a nerve sheath tumor. And this one also came out as a schwannoma. So 2 of them, David, add to your collection of large apical nerve sheath tumors.
Cool, thank you.
All right, now back to the interesting case here. So this is one that I finally got follow-up on. This is a lady who was seen at an outside hospital last year. She's 54, as you can see. And she had cough and some sputum production and recurrent respiratory symptoms. And this is, as far as I know, the first CT she ever had. And you can see she's got some bilateral upper lobe scar and some bronchiectasis. It's pretty, unfortunately, it's pretty thick images. But then you see in the medial right lower lobe that she has this area of mass-like consolidation. And you can see that the airways kind of cut off in here. And I'm showing this not in the order I saw stuff because I saw a follow-up on here. But I will point out that one thing you can see here, which is kind of interesting, is you see these look like mucus-impacted airways with very high attenuation mucus. Anything, of course, in the lower lobes, especially when you don't see airways going into it, always look, this was not a sequestration. But at this time, she underwent a bronch that was negative. They just got some inflammation. They thought maybe she had cancer. She came back the following year and now has this thing in her right upper lobe, this more mass-like consolidation medially, which was, you know, in an area of where she had bronchiectasis before. She still has this thing in her right lower lobe, although it's a little bit smaller. And this time they got a little bit more aggressive because this was still at an outside hospital. She had this right paratracheal lymph node. They actually did a mediastinoscopy, biopsy. They resected one of these paratracheal nodes and then also biopsied this and just got inflammation again in reactive nodes. So no cancer. And then she was finally referred, and this is when I saw her, this study. And of course, looking at the other studies, you know, and looking at what we had here and seeing, especially in the older studies, how it looked like it was all just high attenuation mucus. I called up the interventional pulmonologist and asked him if this lady had a history of asthma or if she had been diagnosed with ABPA, and because that's what I was thinking this was. And then I even threw it, you know, I said, given that it's more mass-like, it could even be along the bronchocentric granulomatosis spectrum of things, you know, with, you know, can sometimes mimic cancer. And sure enough, he went in and bronchhed her again, and this time they got just florid, florid inflammation with eosinophils, acute inflammation, some necrosis, which they think may be a component of bronchocentric granulomatosis, and then fungi that eventually did grow aspergillus. What's interesting, she really didn't have much of a history of asthma. She did have just some chronic cough, and they did a follow-up CT elsewhere. She can't afford to come back to San Francisco, but she had been started on high-dose steroids, and you can see now that she's just left with areas of bronchiectasis, and most of these big casts of mucus and the high attenuation mucus is almost completely resolved. So
very, very impressive.
It's a cool case. Yeah, I think it's a good example of just of ABPA, the spectrum of allergic bronchopulmonary aspergillosis, and maybe, you know, the poorly understood bronchocentric granulomatosis that can mimic cancer. But I think the clue here, even on this first one, was the high attenuation mucus you see in these airways. We don't have a non-con, but you can clearly see they're big, you know, high attenuation iron and manganese salts and whatever else is in these areas of mucus.
Very impressive.
And let's see. Yeah, that was a cool. And then this one is an interesting case. It's not as exciting as the pleural cases that David showed, but this is one that we saw in October. And you can see that this patient has a left pleural effusion. He's also had a median sternotomy, which in itself, you know, isn't that big a deal, because often we see chronic effusions or chronic pleural thickening after median sternotomy, except you look at the prior study and you see that he'd already had a median sternotomy. It was way back in like 2014, and he had no pleural effusion or really no pleural thickening at this time. So you wouldn't expect, you know, an iatrogenic or an operative related effusion to creep up like that. So of course, you know, they did a PE study in the ED. He was having some pleuritic chest pain, no surprise. And like, one of my biggest pet peeves is doing PE studies when you know somebody has a pleural abnormality, just because the contrast timing often hides or, you know, limits your ability to see the pleural thickening. But despite that, you can still see that there is both visceral and parietal pleural thickening. It's pretty subtle here, and it would enhance a lot more if we were doing more of a delayed or venous phase image. I think you can clearly see it down here. So he had no history of cancer, and you can see he just has a little bit of atelectasis in the lung and nothing else really. He had several months of just cough and weight loss and not feeling great and V symptoms, which I didn't know at the time. We just kind of said, you know, differential of, you know, probably some sort of infectious pleural effusion, maybe malignant if he had, especially if he had a history of cancer. And he was kind of lost to follow up to me until I saw a radiograph last week when I was working over the holidays. And in the meantime, he had undergone both a thoracentesis and then actually a VATS pleural biopsy, and it grew out tuberculosis. So this was a tuberculous or pleuritis. It was all necrotizing granulomas, and the cultures grew out sensitive tuberculosis.
Oh.
It's kind of interesting because he didn't really have any, he didn't have any signs of an antecedent lung infection. It was just the pleural abnormality. So,
Very strange.
but yeah, just an interesting case. And then I'll show one more for now, since Seth, I don't know if you've ever seen one of these at the AFIP. I didn't know this could happen in the trachea. This is a guy who is not small, as you can see. He's only 25 years old, presented to an outside hospital with gradually worsening dyspnea and some upper airway symptoms. And, it's always, this was from an outside hospital, but knowing there's something there, it's always easy to see it in retrospect anyway. And you'll see here that this is, you can see how much soft tissue this guy has, but he has this lesion, this more sessile or tracheal mass. 25 is a little young to get squamous cell carcinoma, maybe adenoid cystic, although it's not a great morphology for it. And we've seen other, occasional tumors as well. And I'm not even going to let you guess on this one because it's something that there have only been a couple of reported cases of it, but it was actually a glomus tumor of the trachea. Same thing that you see. Glomus tumors usually occur under the nail bed, and that's what this turned out to be. And it usually occurs, I think, near capillary anastomoses of arteries and veins. And I attached a quick little review because, of course, I had never heard of this. But the glomus cells that surround our arteriovenous anastomoses. So it's not really anything to learn from this other than it can happen.
I actually show one in my lecture on the trachea for weird crap that can happen. And another one. What?
Is there anything to it other than it is a mass that is probably has a better prognosis than most of what we see?
Yeah, no, there's no way to differentiate any, most of these. But I have one that's an aneurysmal bone cyst that developed in the tracheal. Don't ask me. But yeah, I actually have one in my lecture.
All right.
Oh no, I'm sorry. It's mine. I'm sorry. No, I lied. I'm looking at it now. It's a granular cell tumor, which I still don't know what even that is. But
well, you can add this one then too. You can have more G tumors.
There we go.
All right.
I think
it's 1 o'clock.
Okay.
Go ahead.
Travis, I think that Kanne had one of these. Had a tracheal glomus tumor in the past. I'll see